discuss an overview of the current and recently concluded clinical trials in North America for spinal cord injury. And I will focus mainly on the stem cell trials, because that is really the latest information that's out there, and I thought that might be good to discuss. Again, come from cold Milwaukee, Wisconsin to warm Sao Paulo, so it is not only warm here outside, but the spirit is also very warm, so we're very grateful to be invited to come to Sao Paulo. So this is, I thought I'd start with an index case. This is a 24-year-old, he's currently a medical student, he wants to be a neurosurgeon, but at the time of injury he was in college. He dived into a shallow pool and he was quadriplegic because of this burst fracture at the scene of injury as well as in the emergency room. And unfortunately for him, he continues to be Asia A at 1 year after injury. The question here is, what are the options available for someone like this? What are the options now? We've discussed some of it in the last discussion, but what are the options going forward, which is where the clinical trials come in. So I'll talk briefly about education and prevention and early surgery, which we've already discussed. I'll also talk briefly about the neuroprotective strategies and then really focus on the neuroregeneration strategies. From an education and prevention in the United States, we have a number of laws, including seatbelt laws and things like that, that tend to decrease the rates of spinal cord injury. We in our center used to see, we are the only spinal cord injury center in the northern Midwest in the United States, and at least in Wisconsin. And we've seen a drop of Asia A injuries from roughly 45 to 50 a year to now about 35 or so a year. So which means that some of the laws are working. In terms of early surgery, I will really quickly go over Staskis. Again, we already talked about this, so I will not mention any details. But really, early surgery for Asia A through D does improve neurological outcome and reduce a number of secondary complications of spinal cord injury. The neuroprotective trials are, I'm going to really focus on 6 of them. I will not really talk about methylprednisolone because I think we had an energetic discussion at the last panel. And then the remaining 5 that I will comment on are Asuvio trial, which concluded in 2014, the Accorda trial, which concluded in 2015, the Riluzole trial, which is ongoing, sodium pump inhibitor, hypothermia trial, which is also ongoing, and the in vivo trial, which is just finished its phase 1, and we're about to launch a phase 2. So all of these neuroprotective strategies are focused around one mechanism: how to limit the extent of secondary injury in the spinal cord. There we go. So this is the primary injury, and the goal of the neuroprotective trial is to prevent the secondary injury from actually happening within the spinal cord. Methylprednisolone, again, I won't mention much because we've already talked about this. Asuvio was a phase 2 randomized, double-blind, placebo-controlled, parallel group study of a molecule called SUN-13837, and the hypothesis was that would increase the upper extremity motor scores in spinal cord injury patients. It was a proprietary compound. The sponsor recruited 30+ sites. The first dose of the compound was given orally within the first 12 hours after injury. The inclusion criteria were cervical Asia A patients with blunt and non-penetrating injury from C4 to C8, and up to 28 doses, 1 per week, were administered, and there was also some concomitant imaging biomarker measurement at some of the sites. We were one of them. Unfortunately, the Asuvio trial did not work. It was concluded in 2014 because there was not a significant difference in the 2 arms. The Accorda trial, again, this is a proprietary preparation by Dr. Brian Kwan, that originated in Vancouver, another phase 2 double-blind placebo-controlled trial to look at the toleration and the activity of AC-105. Now, what is AC-105? It is a magnesium chloride compound that is formulated in PEG. It starts within 12 hours after injury and completed within 30 hours. So a total of typically 6 doses, 1 every 6 hours after the first dose. Inclusion criteria were blunt, non-penetrating injury, cervical and thoracic, and the endpoints of this trial were safety, neurological recovery, pharmacokinetics, imaging, and serum biomarkers. And the serum biomarkers was basically PK2 biomarker. There was 40 patients that were enrolled. Again, you can see a minor difference in the motor scores and outcome after weeks post-impact, but this was not significantly different if you compared the group that improved with a Corda with a historical control of Asia A patients that only got rehab. So there was no significant improvement conferred by the magnesium chloride compound. So that trial terminated in 2015/16, roughly. Riluzole is a compound that's a sodium ion pump inhibitor. It was approved for other neurological diseases, specifically ALS, and it was noted to be effective. It was started, it's basically an orphan drug. So the North American Clinical Trial Network started an initiative about 4 years ago or several years ago to examine orphan drugs that did not have a patent issue that could be used and had some evidence of use in spinal cord injury. Again, the phase 1 trial was done at limited centers in the East Coast and in Canada. It showed some benefit in all patients of all Asia grades, as shown here. And currently, there is an ongoing worldwide phase 3 trial. I'm sure some of the centers in Brazil are involved. 351 patients are going to be recruited over the next 3 to 4 years. This has already been started 2 years ago. There are currently about 30 trial sites worldwide. It is sponsored by the AO Spine North America, but also AO Spine International. There are some sites in Australia and New Zealand that have recently been recruited. Again, it's a sodium channel blocker. The primary endpoint is neurological improvement assessment at 180 days or 6 months. And the secondary goal is to validate imaging biomarkers, which I'll talk about in my next talk, and that's funded by the Rick Hansen Foundation in Canada. The hypothermia trial, this is really a one-center trial, started in Miami. It's 14 trial patients in phase 1 were completed. 6 had marginal functional improvement, and phase 2 is currently in progress. Again, hypothermia hit the news after Kevin Everett, who was a football player at the Buffalo Bills, recovered. But he also had very early surgery for a C3-4 disc herniation that caused quadriparesis. And there's some question whether it was the early surgery or the hypothermia that was induced that made him improve. So this is the results from the hypothermia trial so far. The in vivo therapeutics trial, again, we discussed some of the mechanisms and how this acts earlier in the last panel. So what is done in this trial is we have done now approximately 8 patients in phase 1. So acute cervical and thoracic spinal cord injury patients are taken to surgery in several hours after the injury. You do a durotomy and then you do a myelotomy. You open the spinal cord, you release the blood clot that is in the substance of the cord, and you insert a scaffold. And the scaffold is supposed to provide structural integrity to the spinal cord such that the surviving axons can grow. So that's the mechanism of the in vivo trial. This is the animal model, of course, and we do it in patients right now. Going to neuroregenerative trials, I'm going to touch on a chronic spinal cord injury trial and then focus on the Asterias trial that really, I think, has a lot of impact. So the Stem Cells Inc., which is a sponsor, looked at neural stem cells that were derived from fetal tissue and were shown to be helpful in a number of different disorders like hypomyelination and lysosomal storage disorders and age-related macular degeneration, and applied this concept to spinal cord injury patients. This was a chronic trial. This was done initially in thoracic, but when we participated, we did it in cervical spinal cord injury patients. A rough area of the spinal cord injury was defined based on the preoperative MRI, and a total of 8 injections were performed of these stem cells, 4 cephalad and 4 caudal to the injury. So that was the mechanism of the trial. And the placement of the injection was determined by an intraoperative ultrasound, as shown up here in the top right panel. So it was a phase 2 proof of concept trial. Again, the cells were derived from fetal brain tissue. Cell injection occurred approximately as early as 14 weeks and up to 1 year after a spinal cord injury. So this was a chronic spinal cord injury trial. And the primary objectives were dose escalation and then imaging biomarker validation. So again, there was some adverse events, but again, this trial was closed because in the first cohort of 5 patients, the Data Safety Monitoring Board that was assembled revealed that there was no significant benefit in these patients, so therefore the trial was stopped. So really the one trial I want to focus on is the phase 1/2 trial of the Geron or Asterias oligodendrocyte precursor cells. That's what OPC1 stands for, in neurologically complete and subacute spinal cord injury. So this is something that I was involved in many years ago as a postdoc at the Karolinska Institute, transplanting human neural stem cells into the spinal cord, showing that the stem cells tend to gravitate towards areas of preserved tissue in the spinal cord and away from these cystic cavities that occur after injury. We also showed at that time that transplanted cells that differentiated into oligodendrocytes, as shown here, this green cell, tended to myelinate. You see this myelination along the host axon. So the mechanism of the action of these stem cells was here in D. This is from a paper published by Sergei Rossignol that talks about the regenerative strategies of restoring function in spinal cord injury, of which remyelination is one strategy. And that's what these stem cells address. And this paper in the basic science end was published in Nature Neuroscience about 12 years ago. Fast forward, and this is how the cells work. Here's a depiction of the acute spinal cord injury. So here's axoplasmic flow in a cephalad and caudal direction. And then it illustrates a blunt injury that delivers a shock to a portion of the spinal cord, resulting in significant reduction in axoplasmic flow, and then loss of myelin that then renders these axons non-functional. They're axons that are alive and that they're viable, but they're non-functional because of loss of myelin. So by doing a myelotomy and then entering into the axonal bundle and injecting these cells, again based on preoperative MRI coordinates that's shown here, you deliver the cells to a specific area of the injury in this fashion, and then that results in slow remyelination that starts really at about 2 days after injury and proceeds to up to 4 months to 5 months after injury. We need to immunosuppress these patients for about 6 weeks to allow the engrafted cells to survive. And this is the mechanism of action here, causing remyelination, and then restoration of signal, restoration of axonal signal in a cephalocaudal direction. And as you see here, the area that has been injured still stays injured, but the remainder of the spinal cord has normal impulse transmission. That's the mechanism of action. The primary objective was to evaluate the safety. Obviously, you want to evaluate safety in these stem cells. And the secondary objective was to evaluate neurological improvement and also to validate imaging biomarkers of spinal cord injury. So again, I keep stressing imaging biomarkers because now I'm setting up for the next talk where we will talk about imaging biomarkers for spinal cord injury and myelopathy as well. So these cells are now available in vials. So when you identify a patient that meets the inclusion criteria, the sponsor sends a team along with the cells that are then thawed and appropriately processed in the bone marrow transplant lab. The initial study was in thoracic spinal cord injury, injecting 2 million cells per patient. This was done about 6 years ago when the company that was sponsoring it was Geron. Again, the patients were identified and then at day -14, and injection was delivered at day 0, and follow-up was supposed to be up to 15 years. Currently, that follow-up is at about 5 years. It was shown in that original study in thoracic spinal cord injury that the cells were well tolerated. There was no immune responses from the cells towards the patients or vice versa. There was good engraftment. Again, we can't prove it, but presumably there was good engraftment, and there was no worsening of neurological function. So this was then advanced into the cervical spinal cord. This happened about 2015 when the study was designed, and we at the Medical College of Wisconsin were part of the design team, along with Dr. Rick Fessler at Northwestern, where the rationale was cervical spinal cord injury has the most devastating impact on quality and duration of life, and that repair and regeneration of axons was required only over a short distance. So you need to remyelinate over a short distance to restore meaningful function. Again, it was determined that if you get a 2-level improvement in cervical cord function, there was a significant improvement functionally for patients because they were able to carry on their independent lives because of that improvement. So there was 5 cohorts that were designed. The first cohort I've already mentioned. We started with the second cohort, which was a dose escalation cohort with 10 million cells delivered into the spinal cord. And subsequently, we've done a dose escalation into 20 million cells. So there's several subjects that have now received, overall 20 subjects that have received either 10 or 20 million cells. And now the inclusion criteria have been expanded to include Asia A as well as Asia B patients. Again, the injection is about 2 weeks after the spinal cord injury has been detected, although the window currently extends from 2 weeks to approximately 6 weeks after injury. Again, this is a phase 1 trial. We've done the 20 patients. The results are currently being evaluated for long-term outcome, and then we will probably design the next trial sometime late summer this year. So there were 6 centers that participated in the study. We were the second center after Rick Fessler at Rush and Northwestern. And this is basically showing a syringe positioning device. It is mounted onto the side rails of a Jackson table, and it has an X, Y, and Z vernier, so you can deliver the cells in a very precise fashion. The safety profile remains positive. No serious adverse events noted. This was the safety profile showing that the patients that received cells were no worse than the patients that did not in the safety study, but this is the efficacy study showing in the first 5 patients after 9 months of follow-up, there's a significant improvement in Asia motor scores. Again, at 9-10 months, this is now the whole cohort of 20 patients. There's a significant 50% or so improvement compared to a historical set of cohorts that did not receive any treatment. So therefore, improved arm and hand function, greater independence in self-care, transfers and transport, and in activities of daily living. The safety profile is good. The upper extremity motor scores is significant, and 2-level motor improvement translates into increased arm and hand function along with improved independence. So there's significant advances in summary in spinal cord clinical trials over the last several decades. It is important to understand spinal cord injury is not a static disease. There are numerous active trials. Really, the future will probably involve multimodality treatment, and the future is encouraging. Thank you very much.